Welcome to the NWAATC Project Echo. I'm Kent Unruh, and I'd like to turn it over to our medical director, Dr. Brian Wood, to introduce our guest.
A big thank you to Bob Leffelbein for doing a talk for us today. I asked Bob to talk about therapeutic drug monitoring because this issue comes up both for us in clinic and it's come up a number of times here on Echo. So I think this will be very useful. And Bob, as you know, is part of our expert panel of pharmacists here on Echo and is a clinical pharmacist at our Madison Clinic. And I will turn it over to you, Bob.
All right, thanks. Brian asked me to just review what's in the DHHS guidelines and also just what our experience has been over the years with therapeutic drug monitoring. So I certainly don't claim to be an expert in this field or anything like that, but we have dealt with it from time to time, so we'll review that. I guess step one is there a commercially available test for the lab that you want? So not all ARVs are listed. We, I think, almost exclusively have dealt with National Jewish in Denver, and this is a copy of their requisition form. So you can find this online on their website, or we can forward that to you however you want. But this is a list of the labs that they have available. We had one, what was it, Atazanavir that we wanted to do, but it wasn't on the list. And I made a few phone calls to the company, and they referred me to a couple of people at different colleges of pharmacy on the Eastern Seaboard, but I never went any farther than that. I don't know how we would requisition through that. But anyway, we pretty much dealt with National Jewish. I don't know of anywhere else that we've dealt with. So there's handling instructions on here, admonitions not to ship it on a Friday because no one's going to be there. And also in parentheses is the time in which you should draw a peak level. So you want to make sure and follow those guidelines. If you do want to get a peak, usually we haven't gotten peaks before, but it's good to know at least what a reasonable time to draw one is. So from the guidelines, basically they're not recommended for routine use. And again, they talked a little bit about not only we always think about efficacy, do we have enough drug around, but also the concept of is there toxicities we could prevent. So that was part of the papers that they referred to. Some of those were written back in 2001 and 2002, which they sounded encouraging, but no one's really taken it any farther. So we do use therapeutic drug monitoring from time to time, and they did give specific scenarios where it was reasonable to do, or at least something that might be helpful. The number one reason we would do therapeutic drug monitoring, or at least it has been, is because of a drug-drug interaction. And so usually that just changes the kinetics of the drug so much, and a lot of times you don't have specific drug interaction data, or always remember drug interaction data is an estimate, or it's the average of what they saw in that study, and there may be a wide response as far as what's going on as the actual drug interaction in that patient. Another thing that comes up from time to time, and we deal with it a couple times a year, is someone who's had a gastric bypass or some other issue that may impair absorption. Really don't have a lot of great answers for that either, but it also seems like a reasonable thing to do. Keep in mind, I guess, with patients like this, you may also have altered peaks and things like that. So when you draw, if you're going to do a full kinetic panel on the patient, that may be altered. But this is another scenario which we've used a time or two in the past. Pregnancy, just because of change in kinetics in pregnancy. I don't recall any cases of doing this, but heavily pretreated patients with biological failure, or just before knowing that they have reduced susceptibility due to lots of mutations, you may want to do kinetics in those patients also. With the onset, or with the fact that we have dolutegravir now, makes this next bullet not as common, but oftentimes doctors have patients who would just refuse to do raltegravir twice a day or other medications. They have to do a compromise as far as the dosing on. So that seems like a reasonable time to do a kinetics daily also, maybe do a trough on that patient. As I mentioned earlier, I can't remember a time we've dealt with this, but maybe as a way to screen for toxicities, but there's so much, there's actually the lack of data with how to make a dose adjustment that I think we'd be pretty nervous about dose reducing from a standard dosing because of a perceived toxicity. So that's something I really haven't dealt with. And then lack of response in adherence patients, that's actually another common thing that we do, just a random trough or a random drug level to see if there's any issue with absorption, or to find out is the patient really taking the medication. I just slipped these in here also just because they're there. Therapeutic drug monitoring in pediatric patients, basically what you'd expect, and they mirror pretty much what was on the previous slide. The other two things that they brought to point was efavirenz apparently has some unpredictable kinetics in children, especially under the age of 3, and then once daily dosing in children in the age of 12, apparently the kinetics aren't too solid with Ritonavir, so that's another time to do drug interactions. And then in pregnancy, from the perinatal guidelines, the adult guidelines say it's reasonable to do in pregnancy, and the perinatal guidelines don't contradict that, but they also don't amplify on that either. They really say there's no real general statement they can make on it, and basically consult each drug and whether or not you should do a dose adjustment or kinetics in a particular patient. So even with the Atazanavir 300 versus 400 late in pregnancy, did not have a solid statement behind it. It was something to consider, but they said consult an expert. From the guidelines also, this is just a table of what they deem to be acceptable trough levels. So something to shoot for and a reference that you can use. Also, if you do send the lab out, then National Jewish will give you an interpretation and give you guidelines as far as what that trough level means. And then also for treatment experienced patients, this is another battery of troughs here, but just keep in mind, just because it's on here doesn't mean the National Jewish has it or that the test is commercially available. And one other thing to point out here is just the fact that issues like with Ritonavir, the mean trough was 3,300, but the range was 1,200 to 7,300. So that's a pretty wide range. And what do you do with the result when that comes back like that? So again, makes it hard to interpret. Okay, so factors that limit the usefulness of TDM: lack of large trials that show benefit for clinical or biological benefit, established ranges, intra-patient variability, so just drawing a trough may be different in a patient from day to day, lack of quality control with those labs, and lack of expertise on what to do once you get those results. So I can only think of a couple of patients where we really made some kind of daring dose adjustments for peaks and troughs off of a patient who was not doing well. A very, very large man, and someone we felt like we needed to do extra dosing on. So we did do some adjustments like that, but that's been a fairly rare event. They also break it down by class of drug as far as what's the most useful or what makes the most sense for therapeutic drug monitoring. So they say that I think they phrase it, the framework exists for the top class here. So PIs, NRTIs, and integrase inhibitors. This seems to have the most potential or the most usefulness for doing a therapeutic drug monitoring. If you are going to do that, then you'll have to consult the latest PK info for that particular drug and kind of compare that with the result you got and make an assessment from there. Also, CCR5 antagonists. I don't recall ever doing a trough for a Amprenavir. I guess it would be nice to know that the dose adjustments we make based on concurrent meds are actually working for a particular patient. And then, as commonly known, NRTIs, those are prodrugs. They have to be intracellular and phosphorylated. So the relationship between plasma level and intracellular level and what that means for toxicity or efficacy just has never been defined, and that's been repeated since 1995 as far as I know. So they haven't made any progress on that. We don't do TDM that often. I guess that's illustrated by the fact that I'm presenting a case from 2006. But this was one of the better examples I could think of, and one that I was personally involved with, so it was easy to kind of conjure back up. This patient was, to his knowledge, healthy and doing fine. He had a tonic-clonic seizure. Was seen at a regional hospital and treated with phenytoin. After another seizure while on phenytoin, they referred him to heart review, and he was diagnosed with HIV and toxoplasmosis. So in a stepwise approach, we added these medications. We continued the phenytoin. We were a little bit obviously concerned about that because that's a well-known metabolic inducer, and we didn't have a lot of data back then, and honestly still don't, about what the interaction was going to be. We kind of decided back and forth and decided to just start with standard dosing of the Atazanavir Ritonavir and watch him closely. So he started, and about 3 weeks later, we got our first trough, and it was really, really low. His viral load did respond, but that's obviously a bad trough, and we decided to go with twice a day dosing. And that brought his trough level up. It dropped back down to 0.46, but we figured that was just natural variation, and his viral load was responding and everything was going well. So we left him on that dose. We were planning on doing further follow-up as far as maybe a month or so later to make sure that he was doing well as far as his trough level, but his phenytoin was discontinued at that point due to thought to be an adverse drug reaction. So we did finally do a follow-up trough on this patient just to see what kind of impact phenytoin had in this patient. And his trough was something like 1.3 or something like that, 1.4. So it's a tremendous amount. Phenytoin beating up the Atazanavir in that scenario. So from 0.5 or 0.05 to 1.3 was the difference of the phenytoin induction. So pretty big event. National Geos had those guidelines for the trough, and I think that mirrors with what we have today is what we should have. For this patient, we got these results, and just for our own assessment, I guess, we wanted to compare that what's in the package insert data, and felt pretty confident that the trough we were in pretty good shape with the trough. The top line on there is what do you see with 300, 100, and then with the boosted Atazanavir, Ritonavir, and the bottom curve is 400 without boosting. So we were at least beating, or at least doing what you'd expect from unboosted Atazanavir, Ritonavir, so we felt like that was adequate for the time being. One thing about this is, in this kind of situation, you want to make sure, for a drug interaction or something like this, you want to be sure that you're getting pretty close to a trough. And this is, my kinetics class was a long time ago, but when you read somebody's T1 half and you back extrapolate or forward extrapolates because you don't have a true trough, that applies to this part of the curve. So because over here there is elimination, absorption, and any redistribution of the drug throughout the body before you get to where the half-life of the drug that you're going to look up actually applies. So it's not a big deal. Most of our drugs have a fairly flat curve, especially when you do ritonavir boosting. You see there's not such an exaggerated curve into that line there, but it still is important. If you draw a level, here and apply the half-life to that, it's not going to be as useful or as meaningful. So a little bit of a kinetics primer for you. Let's see. Oh, and also just keep in mind that's sometimes when you see kinetics graphs like this, it's in a log scale. So keep that in mind as far as making your estimate what your level is. So another example of just what peaks and troughs looks like for some of our drugs and what ritonavir boosting does for that. This is with Amprenavir, not exactly our premier drug anymore, but it does show how you get essentially lower peaks and higher troughs and a flatter curve throughout the dosing interval. So again, when you're thinking about drawing a random level or a trough, that's where are you at on that curve, and are you safely where you're supposed to be, is where you can use that half-life to make an estimate of what their true trough was. So practical issues. Trough may not be easily obtained due to the patient dosing time, so this was always a big issue with the efavirenz, people taking their doses at nighttime and trying to get something drawn during clinic hours. So you may have to rearrange things. And you don't want to do that just one time because your kinetics will not have recalibrated by that time. So you can't just have the patient take one dose at the proper time and then go back to the normal dosing time. You won't have a true estimate of what their trough is. You may need to estimate the trough if it's not drawn exactly on time, and that's what I was getting at. You may need to use the half-life to kind of count backwards or count forwards to see what a true trough estimate might be. I already alluded to drawing the random level too close to the peak, and maybe that throwing your levels off or your assessment off. Then there's the shipping restrictions that I talked about. There's also the turnaround time that you have to build in, waiting for a week or more like 2 weeks to get this result back is what we normally see. Also, just the logistics of getting the dose documented and the time of the last dose recorded so that you can look back 3 weeks later and know that that result is actually valid. Then there's also, if you're checking for adherence, you tell the patient you're coming in for a trough, they're going to start taking their meds again. So you want to kind of sneak up on them if you can and do a random trough if you can, and not let them know that you're going to do a trough. And then lack of data on dose adjustments. What do you do if you get a result? What's a proportional response that you're going to get? We completely guessed with that last patient of doubling his dose and seeing what that would do, but it seemed to work out okay as a rational thing to do. Let's see, practical issues continued. Again, random is going to be less useful for dose adjustments. So I'd really advocate if you're going to do, if you really need to assess a drug interaction or make a dose adjustment, to do a time level, get the trough and get as close to the trough as you can, so that reading will be as accurate as possible. There's enough variability in the game that you want to at least have your value be fairly straightforward and not have any more variables to it. So, and again, that can be difficult to get just because of logistics that I talked about.